Now we have the last lecture, and that is on a very topical subject of FFR, which is the gold standard. And he'll be talking about the new indices which have come up during the last few years. So for that, we have Dr. Rajesh Muralidharan. Rajesh?
Respected chairpersons, dear panelists, my dear friends, it's a proud privilege to be talking about this topic again in this August audience. I'll be talking about FFR, which is still continues to be the gold standard, and the newer indices that that have come of late and are available to many of us. Okay, so. Yeah. If you look at the coronary physiology these days, it's like a la carte menu in a restaurant. We are presented with a bunch of opportunities. You have the option of choosing between a hyperemic index or a non-hyperemic index of measurement of the coronary stenosis or the hemodynamic severity of the coronary stenosis. Depending on your training, your affiliation, your liking, your experience, or the affiliation of your hospital, you may choose between either a hyperemic index or a non-hyperemic index. Of course, in non-hyperemic index, you can have a whole cycle measurement, or a diastolic or a sub-cycle measurement. It all started with FFR after the initial papers by Dr. Lansgold, which happened sometime in late 70s, developed later in 1990s by Dr. Nico Pigelis and his team, and it has been there for nearly almost 3 decades in practice. It still continues to be the gold standard, whereas the newer non-hyperemic indices have come to market of late, and it's a rapidly moving field. Almost simultaneously, technology has moved forward, and now we have 3 angiography-based systems apart from the CT-based systems. You can either have a QFR, the biomedical VFFR, or the CapWorks FFR angio system. This is again rapidly upcoming, and soon we will find that our cath labs are integrated with this angiography-based FFR systems, which are free of wire as well as adenosine. Now, we'll not talk into the details of this. I have no personal experience with angiography-based FFR. We have been doing a lot of wire-based FFR since the first installation of one of the first installations of the machines in our country in my alma mater institution. Now, fractional flow reserve is defined as the ratio between PD, that is the pressure distal to the stenosis, and pressure proximal to the stenosis at maximum hyperemia. All big things have small beginnings. It was the same with FFR. When Nico Pigelis published this paper in 1996, after just 45 cases in which he did exercise stress test, which was a bicycle ergometer at that time, a thallium scintigraphy, and a glutamin stress ergo, and found that using a cutoff value of 0.74, 0.75, myocardial ischemia could be reasonably well predicted with an overall accuracy of around 93%. So this was the beginning of the first major paper to come out of FFR. So we have been getting literature about FFR, and there have been several studies since that, and that is how FFR has now been established as a gold standard. Critical to the establishment of FFR as the gold standard for the assessment of coronary ischemia was the FAME series of trials. We had the FAME 1 trial, which was an FFR guided PCI versus the angiographic guided PCI. The FAME 2 trial, in which FFR guided PCI was medical therapy was treated, it was tested. Mind you, all this was being tested in patients who had stable coronary artery disease. The FAME 3 trial is still recruiting patients. Now, I'll not bore you with the literature much, but you can see why we still consider FFR as the gold standard. Now, this graph, which looks at the timeline of publications titled Fractional Flow Reserve on PubMed, this one I took on 12th of this month. It's like the coronavirus graph of our country. Actually, it's skyrocketing since 2005. There has been a lot of publications, and almost 500 odd publications per year on the title named Fractional Flow Reserve, which means that interventional cardiology community is rapidly embracing this technology of fractional flow reserve, and our understanding and practice of treating coronary lesions is changing from just visual assessment of a stenosis to the functional assessment of stenosis, which is best done at the moment probably with fractional flow reserve. And the future also looks great. If you look at this graph from clinicaltrials.gov, you can see that all over our planet, there are ongoing trials on FFR, be it in any continent. So fractional flow reserve has rapidly caught the imagination of we people, as well as it is the future also. There are a lot of things that are planned with regards to fractional flow reserve in the future as well. Now, just to put things in perspective, let me just quote you two papers, the most recent of the literature, or most recent of the ones that are that's widely quoted, the 5-year follow-up of the FAME2 trial, which tells us that PCI for ischemia reduces the composite endpoint of death, myocardial infarction, and urgent revascularization, as well as reduces MI. So that was the five-year follow-up of the FAME2 trial. The DEFER trial, again, one of the other trials which was pivotal to the establishment of FFR as the gold standard, which tested a strategy that when you have an FFR of more than 0.75, patients were randomized into a DEFER group. Yes, sir, somebody has raised the hands. Is there a problem?
No, go ahead.
Okay. So DEFER trial, actually FFR tested the strategy of FFR more than 0.75. They were randomized into two groups, whether you do the FFR group in one, that's the perform group, versus the DEFER group. And what they showed was that at 5 years, this is the 5-year trial data, when FFR is more than 0.75, the death and MI rate is less than 1% per year. Now, the 15-year follow-up data was published in 2015, which summarizes that mortality, there is no difference. Myocardial infarction, there is a significant advantage in favor of the DEFER group. And repeat PCI and CABG, there is no significant difference. So the DEFER, along with the FAME series of trials, established fractional flow reserve as the benchmark for the assessment of coronary physiology. And the initial tests were done against 3 known standard stress tests. That's dobutamine stress echo, stress thallium, or a bicycle ergometer. That's how FFR technology has evolved over the years, for the past 20 years or so. And this is reasonably well established that of all the techniques or of all the gadgets that we have to improve the outcomes of our patients, FFR not only improves that, FFR guidance not only improves outcomes, but also saves the resources and costs, which means that this is the best case scenario of probably all the gadgets that we use today in our routine practice. Now, despite all this, this graph is actually demoralizing. The adoption of fractional flow reserve technology all over the world remains low. This is from JAC 2017, the post-marketing surveillance, probably from one of the major companies, which shows that in most parts of our planet, the adoption of fractional flow reserve technology is less than 6%. And you know the answer. That's because of the peril of hyperemia. Any one of us who has an FFR know that hyperemia is the point where we get stuck whether we should do it or not. And that is where all this, you have to set it up, you have to give the adenosine, you have to wait for the adenosine to act. This actually adds to the cost and it's cumbersome. So people started looking at techniques where we can do the PD by PA measurement or assess the coronary stenosis without using adenosine. Now, things made a breakthrough after the publication of Dr. Sain Sen's paper, his PhD paper, which identified a period called wave-free period in diastole, which shows that where they identified that the mean flow velocities are higher, the mean wave-free pressures are lower, and the resistances are low and constant. So what they showed was that in this period of diastole, which is defined as wave-free period, which is approximately 25% after the onset of hypoxic launch and 25 milliseconds before the end of diastole, you have a higher flow, a bigger gradient, and low and stable resistance. And you measure PD by PA in that period, you will be able to produce a result almost similar to that of a fractional flow reserve. This technology, they named it as IFR, or instantaneous wave-free ratio, which is defined as the pressure gradient across the stenosis during the wave-free period when resistance is constant and minimized in the cardiac cycle. So contrary to the fractional flow reserve, which measures the PD and PA along the entire cardiac cycle, IFR measures PD by PA in the wave-free period, which I just now alluded to. This was put to test in 2 large trials, the DEFINE FLARE as well as the IFR Sweetheart trials, published in 2017 in the New England Journal of Medicine. The trial design is basically a non-inferiority trial design, which is important for us to recollect. This was a non-inferiority trial design where IFR was tested against FFR, and they showed was that IFR was non-inferior to FFR with regard to the event rate as well as the cumulative risk of composite endpoints. The 2-year data has also recently been published. Although it is supposedly told that it is equivalent, the clinical term would be non-inferior. The primary endpoint was, the proportion with MACE was similar between the FFR group as well as the IFR group, both in the IFR, in the different trial as well as in the Sweetheart trial at 2 years of follow-up. So this established IFR as a non-hyperemic modality to assess the coronary stenosis when compared to FFR, which had a legacy of over 2 to 3 decades of measurement and well-planned randomized controlled trials and outcome literature. So this established a concept of measuring the coronary stenosis without the induction of hyperemia. But people started asking the question, is the wave-free period so unique that no other measurement would be as valid or as useful? The problem was that IFR was confined to the realms of a particular company. You required a particular software which was proprietary to a particular company, and none would have access to that. So in 2017, Dr. Vantivar came with this paper where he looked at IFR versus other probable measurements of PD by PA in diastole. He measured the diastolic pressure ratio in the entire period of diastole, 25 to 75% of diastole, mid part of diastole, IFR using his own software, that is MATLAB, at minus 50 seconds or 100 milliseconds, and then compared with IFR. And they found that all of them correlated extremely well. You can see that the curves are pretty much stacked up. You can see that the curves are pretty much stacked up at the top. All of them are having the same diagnostic accuracy, sensitivity, specificity, positive predictive value, and negative predictive value. So this really opened up the field. It was not about a particular name or a particular software, but it is about measurement at the right place using the right software. And this concept of non-hyperemic pressure ratios, or NHPR as we call it these days, came into vogue. Now, each company has its own non-hyperemic pressure ratio. Philips, Opsens, Abbott, Boston, all of them have it. But the more important point is that all of them have the same cutoff value of 0.89. So FFR has a cutoff value of 0.80, the hyperemic gold standard pressure index, whereas the non-hyperemic pressure ratio has a cutoff point of 0.89. Of course, the definitions are different, and each of these non-hyperemic pressure ratios is proprietary to a particular company. Now, let's talk a bit more about resting full cycle ratio, this is the one that most of us are familiar about, which is proprietary to Abbott. Now, RFR is the lowest sub-cycle PD by PA, which is calculated as a moving average. So FFR is calculated against the full cycle, IFR in the diastolic wave-free period, whereas RFR is the lowest sub-cycle PD by PA, which is calculated as a moving average. Now, this was put to test in the Illumin 1 and Predict trial and showed an overall accuracy of around 80%. Now, I'll explain what is a resting full cycle ratio. You measure the PD, you measure the PA, the average is taken as a broken line. The software develops an instantaneous PD by PA. You apply the filters, and you then get the lowest filtered PD by PA, which is defined as RFR. And by this algorithm, what we find is that the lowest PD by PA need not always be in diastole, where we expect maximum flow in cardiac cycle. Approximately 12% of the cases were outside of diastole, or probably outside of diastole. This was tested in against IFR, and it showed an overall accuracy around 97.4. Now, if you are wondering about what about outcome studies for the non-hyperemic pressure ratios, this Korean study, which was done in around 30 centers in Korea, this IRIS FFR study, they did FFR in all the patients, and they deferred it based on FFR value only. And offline, they calculated 5 indices: resting PD by PA, the virtual IFR, DPR, RFR, and TFR. And what they found was that the deferred failure lesion failure rate, the deferred lesion failure rate was similar for all the non-hyperemic pressure ratios, IFR, DPR, RFR, or DFR, with the same cutoff point of 0.89 compared to FFR. We'll not discuss this as non-hyperemic pressure ratio, because this is something different. But of all the non-hyperemic pressure ratios, the most commonly used ones, the IFR, DPR, RFR, and DFR, all of them are having the same cutoff point. All of them are having the same deferred lesion failure rate compared to fractional flow reserve. The prediction,
Rajesh, sorry to interrupt. You have 1 minute left. Try
yeah,
to summarize.
yeah,
Yeah, thank you.
okay, sir. Fine. So the prediction of FFR and IFR was also similar. So I'll just summarize as discussed by the. Now, when we say that the non-hyperemic and the hyperemic pressure ratios are equivalent, you must always see that the trial design was a non-inferiority one, and the study populations were different. If you compare the FAME trial versus the FLAIR series of trials, you can see that the FLAIR trials in FLAIR group of trials had a lower risk population compared to the higher risk population on the FAME series of trials. So to summarize, what about FFR and non-hyperemic pressure ratios? This will be my last slide. In case of stable ischemic heart disease, you can use a FFR or a non-hyperemic pressure ratio, predominantly IFR or one of the likes. But please understand that the non-hyperemic pressure ratios are tested only in low-risk populations. ST elevation MI, culprit, no. Non-culprit is okay for an FFR. Cori IFR is better as per the recent analysis of the defined FLAIR trial, but there are no outcome trials with regards to non-hyperemic pressure ratios. SVG graph FFR is tested, not a non-hyperemic pressure ratio. The biology of the declaration is probably different. Osteal lesions, left vein, there are no outcome trials for any of the non-hyperemic pressure ratios. FFR, there are a few, but there are issues with IV adenosine, downstream disease, etc. Serial lesions, IFR pullback with anticoagulation registration is thought to be a shade better because the crosstalk between lesions may be less when you have serial lesions. Bifurcation lesions may be better tested with FFR compared to non-hyperemic pressure ratios with outcome data as well. Thank you for your time, sir.
Thank you very much. Now, Dr. Bhattacharya, you handle this question answer session. We have 8 minutes left because Dr. Sarat Chandra wants that this session should finish at 2. So over to you. There are a number of questions in the Q&A box. So Dave?
Yeah, can you hear me, sir?
Yes, I can. So start.
Okay, so I've opened the question and answer box, and the first question is in ISR patients on OCT imaging, how can we decide to use DEB or DES? So that question I think goes to sorry, I've forgotten the name.
Yeah, I will take the question. I am Dr. Shiva Kumar.
Yes, Dr. Shiva Kumar, please answer. Yeah.
DES or DEB based on OCT. It is a tough question to answer because decisions were so far conventionally, traditionally have been made angiographically. Even if you take certain decisions based on OCT, by angiographically, if it is diffuse and extending beyond the stent, you will be forced to forced to put a stent. For example, the stenosis could be focal, but if it is coming at the edges, still you need to go ahead with the stent. But when you're asking really, can we take a decision based on OCT? Well, on OCT, if the ISR is very focal within the stent, if the property is soft in nature and your preparation has done the job, and if you want to avoid a stent, well, you can get away with the drug-eluting balloon because for a focal lesion with an OCT telling you now the volume of the intimal growth after the preparation is taken care well, you can call off with the drug-eluting balloon alone. But at the end of the day, the decision for DES versus DEB cannot be based on one modality alone. We need to combine angiography as well as an OCT. OCT basically tells you what kind of a pathology you are dealing, how prepared how best the preparation you have done, and leaving it to DEB or DES, it's a multifactorial.
Yeah, so let me summarize that. So if it is beyond the stent, obviously the DEB won't work. If it is diffuse in-stent restenosis also, then probably you would not use DEB. If it is focal, and if it is well amenable to balloon dilatation with a good lumen area after balloon dilatation, then I suppose you would opt for DEB and not another stent. Is that a
Yes.
fair summary?
Yes, sir.
Okay. So let's move to the next question. Dr. Balbir, if you're still there,
Yeah.
when do you wire through proximal struts, and in what case do you go through distal struts? This is a question from Dr. Anil Kumar.
Right. So it's a very good question. So if we are doing a provisional stenting and we need to do a kissing at the end of the provisional stenting, a distal crossing is the best way to do it, because you want to, as I showed in one slide, if you do a distal crossing and do a kissing balloon, you will have those struts hit against the wall of the ostium of the side branch and help to prevent restenosis. However, when you're doing a decay crush or a mini crush, a proximal crossing is useful because you would align the next stent against the wall. So it is mandatory to do for provisional distal crossing, but some people I know do distal crossing even for a decay crush. But we prefer to do a proximal cross for a decay crush. But for provisional, it has to be a distal cross.
Okay. So let me ask you a follow-up question on that. So if you have a side branch which is very, very difficult to recross, and then you do the OCT and you see that it is the wire cross is not ideal, would you take the wire out and then try to recross again? And if you have done that again, would you do the OCT again?
So a very practical question, and if there is a difficult rewiring, I would not bother to see whether I have crossed it properly or not, because I may not be able to recross it if it was initially difficult to cross. I would only come with an OCT in such a situation if I'm not able to get my balloon across that wire on the side branch.
Okay, okay, thank you very much. Yes, that is a very sensible approach. Thank you, Dr. Balbir. And the next question is by Dr. Saurav, and that is also pertaining to ISR. So Dr. Sivakumar can take this. What is the best way to prepare fibrous ISR? Is it better with cutting balloon or NC?
I think I will opt for a cutting balloon. If at all NC balloon, that will be after the cutting balloon. If there is a combination of proliferative as well as under-expansive ISR, then I will first prepare the tissue with the cutting balloon. For the under-expansion, I will take the help of NC or OPN. Well, there is a big insight coming up with the laser atherectomy, particularly in a proliferative ISR. So, particularly in a multi-layered resistant ISR. If it is a multi-layer resistant ISR, to start with laser, of course, the availability is an issue. Availability is an issue and it is not a multi-layered. Well, if it is proliferative alone, I will start with cutting balloon. If it is under-expansive ISR, NC balloon. If it's a combination of both, I will use both.
Okay. Well, thank you very much. I have a question for Dr. Hiremat. Is Dr. Hiremat still here? Is Dr. Hiremat still here?
No, sir. Dr. Hiramat left.
I think Dr. Kaul can take that question and answer.
Okay. Okay. So, Dr. Kaul, I will ask that question to you. So, if you have a lesion that is very calcified, and you are not able to pass either IVUS or OCT catheter across the lesion, what would your approach be? Would you try anything else, or would you just go ahead with rotator blade?
This is a situation I would not, waste much time by, taking balloons and other things. I will just go in with a rotor wire and take a 1.5 bar, debulk it. Then you can do, then you can do IVUS or whatever you want. Then I'm sure it will go through. Or then you can dilate it also, and then you'll get the lumen, and then you can do intravascular imaging much better, easily.
Yes, sir. And once you have done the rotablator, you would do the imaging and then decide on your next plaque modification strategy. As we were discussing, that you need something more than just rotablation in a lot of cases for further plaque modification. And how many of your cases these days do you use IVL after rotablation to do further plaque modification? And how
Well,
easy
my
it is to pass the IVL after you have done rotablation with a 1.5 bar?
experience is limited, but I have done one case of this kind where we did a rotablator, but the imaging was still showing enough problem there. So then we went with and the balloon was not fully expanding. Now the question was to change the guiding catheter to a bigger guiding catheter, use a 2 millimeter bar, and other was IVL. So we used an IVL, got much better the debulking, and then dilated it, got a perfect result, did a OCT, and the result was good. So I
Yeah.
think we have, many leverages these days. It's not those 10 years ago that you had one or two devices. You had devices to choose. You had the cutting balloon, you have the IVL, you have the rotablator. And, I think most of the cases, that's why we can be doing uh, quite complex cases.
Let me ask you one more question, Dr. Kaul. This is an issue that troubles me, and that is the high pressure balloon that is now available. So if you were to see on imaging that there is a lot of calcium and it is distributed around an arc of 270 degrees. In other words, the artery has room to expand only in a very short arc of the vessel. Would you go with a high pressure balloon there and try to expand it to 40 atmospheres, or would you first do plaque modification with rotablator and then use the high pressure balloon?
I think the second strategy is much better because, first of all, the OPN balloon has a much bigger crossing profile, is not going to go, but even if it goes, it is unimaginable that it's going to break all that calcium and make it a smooth lumen. So I think the best strategy is to debulk it properly. After that, yes, after your balloon expansion, you still see that there is residual. Then instead of upgrading the bars and other things, then you can try this opium balloon. And opium balloon basically is also useful when you have deployed the stent and your balloon, which you have post-deployment high pressure balloon, is still not giving you a good picture. You see at the road map or look at the stent boost or stent whiz, you see that a localized portion hasn't expanded, although you did debulking also. That is the situation where this 30, 40 atmosphere high pressure balloon works. Very often it works.
Dr. Kaul, could we go for the next session?
Yes, yes.
Okay. Yeah.
Thank you, Devdutt.
Yes, Dr. Sharatchandra. I had one last question for Dr. Sridhar Kasturi if he's still here. But if you think that you need to go to the next session, please go ahead.
Yeah, I think, we are really beyond time.
Okay.
Let's go to the next session.
Thank you very much. It was very enjoyable. Thank you.
Thank you so
Dr.
much.
Kaul, Dr. Sharatchandra. Thank you. And all the presenters. Thank you very much.